Thank you, everybody, for joining this event on time series analysis of routine health data, challenges and opportunities. My name is Mona Kanan. I'm a professor in applied health research and statistics, and I am the chair of the medical section of the Royal Statistical Society. And it gives me great pleasure to introduce this session today. And before I actually start anything, I would like to thank you all for joining in and to thank our speakers for taking the time to put this webinar together. So much appreciated. What I'm going to do now basically is a brief introduction to the Royal Statistical Society. And in specifically the medical section, which puts this event together. So just a reminder, this event comes under the umbrella of the Members Week, and we're basically trying to introduce the society across what we do. And we are a professional body of statisticians from different creeds, be it theoretical statisticians, applied statisticians in from different disciplines as well, and data analysts. And we are in fact global. We have a global reach. A quarter of our membership, 10,000 membership, is from outside the UK. And our key role is basically to advocate statistics and data in society and work to ensure that policy formulation and decision making are informed by evidence for the public good. And this is, has been crystallized during the current pandemic, the importance of having good statistics in driving local and global decision making. In addition, we have different types of memberships as well. If you're interested and you're enticed after this session to join us, so please do. I'll at the end of this presentation, I'll as well share in the chat box the different links that you might want to, if you're interested in the society to look at. So wait for this space. I'll be presenting them in these slides, but wait for me to add them to the chat box because it might be easier for you to click on. So thank you. And so that's our vision, is that our data is at the heart of understanding and decision making. We have a number of sections and local groups and special interest groups, a total of 16 sections plus the young statisticians as well, specifically for young statisticians. And within different localities, we have local groups that come together and put events as well. And some of these local groups are, spread across the UK. And some of them are even outside the UK, for example, the Nigeria local group. And then there are special interest groups, which is basically, they haven't yet been sections, but people are really interested in looking at trying to form a section, including, for example, women in data science and statistics, data ethics and teaching statistics, in addition to finance and economics. So I'm just going to briefly now, and this is the link, basically, if you want to know a bit more about our memberships. We put on a number of events, including our annual international conference, which happened a month and so ago, 6 to 9 September 2021, and the upcoming one is in Aberdeen, 12 to 15 September 2022. Our organizer, Ruth, will tell you a little bit more later about it. I hope so, Ruth. Okay. So I'll just briefly introduce the medical section, which I chair. And this is basically the medical section aims to develop and support application of statistical methods in all branches of medicine and, in fact, healthcare statistics. So any type of health data related that can inform decision making. What we do is we organize 4 to 5 meetings per year, this one included, for example, and support high quality meetings focused on issues of importance to medical and healthcare statistics. For example, we've contributed in the 2021 conference 5 invited sessions to that conference. And these range from Bayesian inference to other as well, things like basically looking at reviewing the importance actually of acting as a reviewer, as a statistical reviewer, methodological reviewer for medical journals. And in addition, where possible, we try to work with other appropriate sections and non-RSS organizations to promote medical and healthcare statistics. Our latest collaboration was with NIHR Statistics Group, where we did a workshop on statistical literacy in health research in the age of artificial intelligence and machine learning. And we have quite a bit of work with the Young Statisticians and RSS Publications Network. This is in addition to our joint effort with London School of Hygiene and Tropical Medicine annual Bradford Hill Lecture. And we've done as well to celebrate the bicentenary of Florence Nightingale in 2020. We planned a number of events. Some of them went ahead in 2020 and some of them were postponed for later dates. As well, we've been working, some of you might have received this survey and contributed to this survey, which is the RSS Professional Recognition of Medical Statisticians. We're still working a bit more on the data, and we'll probably share with you that when we finalize the analysis. In terms of officers, these are on the right-hand side, my right-hand side at least, basically, and you see we are a number of people coming together from across different walks. Okay. Now, if you're interested, if you think that's the medical section or RSS is something that you'd be interested in contributing to, and as a nice forum of discussion in terms of medical statistics, healthcare statistics, and other types of statistical issues, please do look at our membership group and specifically the medical section. In addition, if you're not simply interested in becoming a member, you can, however, subscribe to our mailing list, and here are the details of how you can do that. We are currently seeking new committee members, and the deadline for this is next week. So please, if this makes you interested, please do put yourself forward, and you can follow us on social media, Twitter, YouTube, and SoundCloud, where we have a number of basically presentations and podcasts related to the work we do. I think I'll stop here, and thank you very much for listening to the introduction of the RSS.
I'm actually delighted to introduce our speakers because they have quite a lot of experience in applying complex methods to time series routine health data. And I will start by introducing Dr. Laurence Watier. So Laurence is a permanent researcher at the National Institute of Health and Medical Research in France, also called Inserm, and also at the Institut Pasteur. So her areas of expertise are biostatistics with respect to Bayesian methods, mixed models, and time series analysis. She has done a lot of work in epidemiology, as well as public health and the use of medical administrative databases. Her work recently has been focused on public health impact of changes in exposure to antimicrobial drugs, and also on medical economic cost of bacterial resistance to antibiotics and foodborne illness with attribution models. And a very interesting fact about Laurence is that she actually did her PhD under the supervision of Professor Sylvia Richardson, which is our current RSS president. And I can assure you that I did not know that when I invited her. I just thought she was doing fantastic work, and I really wanted to hear more about it. our second speaker is also very experienced in this field. So Professor Antonio Gasparrini, he's a professor of biostatistics and epidemiology at the London School of Hygiene and Tropical Medicine. He works a lot in environmental epidemiology, but he does methodological work and development of study designs and statistical methods applied to time series. He works also with quasi-experimental studies and survival analysis, and he has developed a number of statistical techniques, such as distributed lag models, smoothing methods, and meta-analytical models. So I think we are here for a treat. And Laurence, would you like to take the stage?
Hello to all. First, I would like to thank the medical section of RSS and in particular Ruth for inviting me at this meeting. My talk is not technical focused. I'm sorry, Ruth. The model considered are extensions of the well-known linear model developed by Box and Jenkins, and using 3 examples of the topic of antibiotic use and antibiotic resistance, I will highlight the key points to keep in mind when studying time series, and in particular those related to data sets. The result will be minimally commented on. I invite people to refer to the articles for further details. In the early 2000s, compared to European Union countries, France has the highest consumption of outpatient antibiotics use, the highest rate of beta-lactam resistance in Streptococcus pneumoniae, and a significant number of antibiotic prescriptions are given for viral respiratory infection for which they could be inappropriate. In November 2001, the government initiated Keep Antibiotic Working, a national plan to preserve the effectiveness of antibiotics and improve their use. This plan linked to 2 major public health interventions, a campaign for reduction of antibiotic use, followed by the recommendation of antipneumococcal conjugate vaccine. I will present 2 published works related to the assessment of those 2 campaigns. Both use an intervention Rmax model. I suppose here that the series is in a stationary mode except for the intervention. First, it is essential to take into account dependence between observation. Thus, the error terms were modeled using ARMA process. Second, for assessing and quantifying the impact of intervention, there are several options, but the simplest one was sufficient, that is, including dummy variables allowing estimating changes in the average level of the series. Finally, the X for exogenous variable allows taking into account a confusion time series, which we have used the simplest transfer function assuming a linear relationship between both series. In practice, the 2 first steps allows measuring the impact of the intervention. We first work on the series before the intervention, the so-called baseline period. We need to have a long enough series to estimate the ARMA model that generates the series. It is assumed that the intervention only affects the average level and does not change the underlying process. Similarly, if the series exhibits seasonality, the intervention is assumed to do not modify seasonal fluctuations. After, we estimate the identified model in one on the whole series by introducing in an additive way dummy variables. After, lastly, we could include the confusion time series if necessary. The French antibiotic reduction campaign was launched by the French National Health Insurance System. It targeted the general public and healthcare professionals to raise awareness about the appropriate use of antibiotics. It was implemented into 2002 and again every year from October to March. The campaign aimed at reduced prescription, in particular during the VRI epidemic season and among children. This campaign is already finished since a long time, and a future launch by Santé Publique France, the French Agency of Public Health, is coming soon. Data comes from three sources. The data on antibiotics come from the NHI. It is healthcare reimbursement data. We have access to anonymous individual data from two main agencies and have written outpatient antibiotic for systemic use. To take into account French population growth during the study period, we use demographic data obtained from the French National Institute for Statistics and Economic Studies. Viral respiratory infection data come from the Sentinel network. Since antibiotics are prescribed for VRI, there are potential confounders. Indeed, without any effect of the campaign, we could have a reduction just because the VRI circulation is much lower, by example. Before moving on, the quality of the data must be checked. What is the representativeness of the sources, and what about temporal stability? Indeed, since we are using an indicator to study a temporal evolution, it is important to ensure that any potential bias do not change over time. The coverage of NHI is high and stable since 2000. The Sentinel network is based on only 2% of the GPs, but it was demonstrated that estimated incidences were valid at national level and general population only. 2 time series were constructed, the weekly number of reimbursement antibiotic prescription divided by population size, and the weekly ILI incidence from 2000 to 2010. But are these indicators good measure of target? That is, are reimbursement a good measure of prescription? Yes, because in France, the majority of the population is covered by health insurance. The antibiotic is a medication subject to reimbursement, and its delivery can only be with a prescription and not over the counter. However, a refund does not mean that the individual has consumed their medication, which is not an issue here. Is ILI a good measure for VRI? Not so much, but it is the only one available for the period at this time. Here you can see the weekly antibiotic prescription, the ILI incidence, the baseline period pre-campaign, the campaign and warm period defined to measure the impact of the intervention. No difference is expected during warm period. Antibiotics presents seasonal fluctuation. Thus, on baseline period, we have estimated a trigonometric function. Since that is, as I said before, we assume that the campaign does not affect the seasonal fluctuation, we remove it to the entire series to obtain a non-seasonal series. The ARMA model was identified on the baseline period and fit to the non-seasonal series, including 15 dummy variables, those ones. Here are the fit of the model and the estimation of the relative change. The gray series are the observation. The red, the prediction. On the post-campaign period, here, the gray or black line is the expected antibiotic prescription level during CI, here, and WI period. And those was expected under the assumption of no change since the baseline period, that is, no effect of the campaign. This is the same as baseline period. And the red line is antibiotic prescription level during both periods predicted by the model. The percentage over here represents the relative differences between the black and the red compared to the baseline period. Overall, the campaign was efficient with a maximum decrease after 5 years. As you can see, no change was observed during the warm period. Here are represented the relative risk compared to the baseline period by age group. We can see that for the elderly in red here, it's the campaign period and here it's the warm period. For the elderly, the campaign have a lower effect and during a small time. And in the warm period, we observed an increase. So a better understanding of antibiotic use in the elderly is necessary to carry out target public health action. I will rapidly present the impact of the French pneumococcal conjugate vaccine program. This program was launched in 2003 with the aim to decrease invasive pneumococcal infection and beyond pneumococcal resistance. The target population of the vaccination was the children less than 2 years old at risk of IPI, but after 3 years, the vaccination was recommended to all the children less than 2. The first PCV includes 7 serotypes on the 97 known. After its introduction, a decrease in IPI due to vaccine serotypes in both children and adults were observed, but was also observed a serotype replacement phenomenon, that is an increase in non-vaccine serotype, leading after 5 years to an increase in the incidence of IPI in the general population. In 2010, a new PCV was recommended. It includes 6 more serotypes. As with the previous vaccine, a decrease in IPI due to the 6 additional serotypes was observed, but also the serotype replacement phenomenon. And this time, emerged serotypes were different among countries. Before, it was the same around the world. The aim of the work was to measure the impact of PCV program on IPI using Timeseries analysis. IPI data comes from the National Reference Center for Pneumococcus. It is a surveillance network of more than 40 microbiology laboratories. All strains of meningitis are sent. For bacteriemia, all strains of children, but only 6 for adults. For each strain, serotyping and susceptibility to most common antibiotics are performed. As previously, to take into account French population growth, we use INSEE demographic data. And since the literature suggests an IPI influenza virus interaction, we also use ILI from Sentinel network. The coverage of the reference center is high and stable since 2000. Related to bacteriemia, the low representativeness for adults is not a concern as their number is large. However, this bias must be stable on the period. But you can see here in red that in 2004 and a part of 2006, no strain of adults of at least 60 years old was sent to the center. In gray, it is the expected number of bacteriemia provided by another source that unfortunately we cannot use since serotype and status to the antibiotics are not available. For meningitis, we have a temporal stability of the surveillance. Thus, we work on monthly number of pneumococcal meningitis in total by serotype group and for the two most exposed age groups on the period 2000 and 2001 to 2014. Since meningitis is rare, we have aggregated the data at month level to be able to use the same methodology as previous. But beware, aggregation leads to a loss of information, which can be damaging in some cases. In this study, the written period to measure the impact of the vaccination were the epidemiological year, that is July year N to June year N+1, in order to avoid splitting the winter. The color code is the same as previously, and you can see that in France, a decrease in PM for the general population was observed 11 years after the introduction of the vaccination. As expected, the evolution depends on the serotype. Vaccination was efficient since, compared to the pre-vaccine area, the PM due to PCV7 serotype in blue have nearly disappeared before introduction of the vaccine, the second vaccine. For the PM due to the 6 extra serotype of the second vaccine, in yellow, after 3 years of its introduction, the decrease seems stable around 40%. You can note that the decrease starts before the introduction of the vaccine. The increase in non-vaccine in red seemed to have stopped shortly after the introduction of PCV13. Results suggest that vaccine pressure alone does not explain pneumococcal epidemiological changes and that other factors could play a role. My last example focuses on the estimation of attributable fraction from time series. The exposure attributable fraction is a proportional reduction in the outcome that would occur if the exposition was removed. This paper formalized its estimation for commonly used model. For Gaussian time series, first, a linear regression model with autocorrelated error, including exposure, is fitted, and then the exposition is removed to predict the outcome. For seasonal outcomes, a sinusoidal component can be incorporated to the model. The prediction, the observation is this line. The prediction without the exposure is a gray part. And the blue line indicates the period where the fraction is calculated. In France, outpatients represent more than 90% of antibiotic use, for which beta-lactam and macrolide are 2/3. Those are prescribed for VRI and could be inappropriate. We know that antibiotic overuse and misuse contributes to the emergence and dissemination of antibiotic resistance. It is thus important to assess the proportion of prescription that could be avoided. As previously, antibiotics come from National Health Insurance and demographic data from INSEE. Data for VRI come from OSCOR network monitored by the French Agency of Public Health. It's a network of around 600 emergency departments. Daily individual patients for syndromic surveillance are recorded, in particular, ICD code for diagnosis. The network represents a high percent of ED attendances, and the coverage is stable since 2010, 5 years after its implementation. Weekly time series on the period 2010 to 2027 were constrained. The outcome was the number of antibiotics prescription, and the exposure was the number of visits to EDs of 5 syndromic groups, 4 specific, bronchiolitis for children, bronchitis, ILI, and pneumonia, and a global one, which includes the 4 specifics plus few others respiratory infection. We have considered that emergency departments were a good proxy of community lower respiratory tract infection and that the coding was as good enough. Indeed, the indicator of ELI from Auscore network was similar to the one from Sentinel network. But these were not considered as good proxy for community upper respiratory tract infection. Here are the series for children, the antibiotics. You can see bronchiolitic in purple and in blue ILI. Each group are split in viral and non-viral. There are 2 models with global and specific LRTIs. Each estimation corresponds to a separate prediction. Results shown that children of the overall antibiotic prescription in winter, the majority are prescribed for viral LRTI and near 24 bronchiolitis only. For the elderly, the majority were prescribed for non-viral LRTI. If antibiotic for viral LRTI is inappropriate in 50% of outpatients, this corresponds to 800 prescriptions per 100,000 inhabitants per week for children, which highlight the major role of viral infection in driving antibiotic prescription in children. In conclusion, surveillance system or medical administrative databases are useful tools to construct time series. They allow constructing long time series permitting time lag aggregation for using linear model, by example, many indicators and addressing many topics. But the longer the study period, the more changes in the data collection are possible, introducing a temporal dynamic modification. Ensure that bias does not evolve on the study period. It is thus important to have a good knowledge of the data sources, to check quality of dataset, to ensure the indicator fits the question, and when possible, validate with another data source. I hope to have demonstrated that models based from box and checking technique are well suited for that kind of data. They allow answering many questions. Simplicity and parsimony of such models are adequate in our context and easy to interpret. But keep in mind, aggregation limit causality, find arguments in favor of causality, and use control time series when possible. But the increase in the number of data points increase the power of diagnostic tests, in particular independent tests. Thus, due to parsimony principle, decrease the p-value threshold instead of complexify covariance structure. Some hypotheses are required when interested in attributable fraction. Attributable leads to causality between the exposure and the outcome, but most often it is an association. When we have several exposures, additivity of attributable fractions assumes independence of exposure. Finally, it is important to ensure that all exposure have been taken into account. Indeed, if a significant exposure is omitted, its attributable part will be split between the other, which could artificially increase the fraction. In previous example, if non-viral LRTI are omitted, attributable fraction related to viral LRTI will increase since both were correlated. However, when dependency structure is complex, ARMA are non-sparse model and covariance structure is difficult to interpret in an epidemiological context. A new alternative that I mentioned quickly is Hawk process, which are point process. However, Chesson and Lang recently proposed an adaptation of the Hawk estimation method for aggregated data. Hawk's process are useful, in particular when the events are rare and highly contagious. And it was recently used for COVID. I would like to thank all persons who have contributed to the presented work and the other audience for its attention. Thank you.
Thank you very much, Laurence, for this interesting presentation. We have a couple of questions in your chat. So the first one is from Roger Morbey. So he posted this question when you were in slide 15 of your presentation. He's asking is this the same as interrupted time series analysis?
Sorry, which number?
Slide 15. So I think it was your latest example.
Attributable fraction?
Yes.
It's not the same as interrupt time series, but intervention model could interrupted time series. It's a regression where you compare an evolution before an intervention, before a point. It's not the same, because interrupt time series, it's a regression before and after, and you look at the slope. You compare the two slopes. Here, we have a model including all exposure. That is, we have outcome antibiotics and exposure bronchitis, by example, bronchitis pneumoniae. We fit the model, we predict, and we put bronchiolitis at 0 to have a prediction without the exposure. Is it clear? Is it more clear or not? I don't think.
Let's hope it is. So let's go to the second question. So from Rebecca Killick. So how do you deal with potential lags between the intervention and a response?
In our example, it was, I didn't, for the PCV, by example, we wait 6 months before to see an effect. And we prefer to take the simplest model, because we can have a response delayed to the intervention. And there is some tests. I think Tiao and Box propose a test. You have the theory before, you make prediction, and you look when there is something appear different. How we deal, it's you speak with people who knows about some phenomenon, and you try. The impact of the French campaign was just in the first year. There is a decrease, significant decrease, but it was 1 year ago. We speak about a lot of antibiotics use, too many in France. So it's not rare. Sometimes you have an effect before the intervention arrive, because it's intervention in the media. They speak a lot before, and the people are sensibilized. I don't know if.
No, that's fine. So there's 2 further questions, but let's move on to the next talk by Antonio, and then we can address them at the end. And Antonio, feel free to use your 30 minutes. We'll have a little bit of extra time, okay?
Oh, very good. First of all, I will show my slides. I hope you can see them. Well, if so, I will start. Well, first of all, I want to thank you, the Royal Statistical Society, the medical section in particular, for organizing the event, and the organizers for inviting me. I'm very glad to be here to present this work and this model, let's say, this new design I've been working on in the last couple of years, and it's called the case time series design. Now, we'll start presenting a bit the context, and the first speaker has already probably provided a very good overview. Nowadays, we are flooded with data from many different sources, in particular electronic records, real-time data technologies, just like mobiles or remote sensing measurements. And of course, we are able to put together with these amazing databases, with all the limitations that have already been, in a way, listed, and to run potentially very large epidemiological analysis. Now, the problem is the data setting is very complex. You have individual risk profiles and these longitudinal repeated measure settings. And of course, this poses some issues in terms of how we model this data. Now, in order to present, in a way, the development of a new study, I will start with a very simple methodological case study. And let's assume that for a set of subjects, I listed 4 in here, but of course there are usually more, we are able to reconstruct their profiles in time, and throughout these profiles, we are able to measure when they are exposed, for example, when they are not, assuming in a very simple case a binary exposure, which is represented in here by these yellow periods, and especially when they experience outcome events, for example. Of course, these simple example can be extended to have multiple events, to have different type of outcome, for example, continuous outcome, and at the same time, continuous exposures. Now, this setting is used for several examples. For example, examining short-term, what we call transient associations. And for example, it can be physical exercise and myocardial infarction, air pollution and asthma, or paracetamol use and gastrointestinal bleeding. So in many different settings, you have more or less always the same setting that you can reconstruct with this data. Now, in time, many different study designs have been proposed, and I'm focusing here in so-called self-matched study. The first I'm presenting is this case crossover design. It was presented by Malcolm McClure in 1991, in a paper in 1991. And what McClure did was really smart. That is, in order to establish this association, instead than comparing different subjects, possibly at the same time, I will compare the event times with control times in the same subject. And therefore, I'm defining this within subject matched risk set that forms the basis of my comparison, and I can add the information throughout all the subjects to get an estimate. Why this study is so clever? Because by self-matching, in a way, this comparison, you exclude any potential biases that is due to structural differences between subjects. So you don't even have to measure them because you are sure that they are not affecting your estimates. Now, of course, there's been an intense methodological work on this, and especially most of these, how you sample these controls for a given event in a given subject. But of course, this is another story. I will suggest most of you to read the literature, because it has a methodological literature on statistical methods for epidemiological studies is amazing. Now, at pretty much the same time, there were another group team led by Paddy Farrington at the Open University, early 90s still, proposing a completely different study, but with similar characteristics. So what they did, they defined this self-control case series, actually, not case time series, self-control case series, not time series, which is a different design based on a cohort logic. So instead of taking an event and few controls, they considered the whole follow-up period for each subject, and they divided it in exposed and unexposed period, and this formed a contrast of rates of occurrences of particular events in exposed versus non-exposed times within the same subject. So the study is still self-matched and therefore has all the beauty, in a way, of the previous case crossover study, meaning you don't have to control for any time invariant factor, and this doesn't cause any bias, but it uses the whole follow-up period, the whole information for the individual. Of course, it has some disadvantages, meaning it's not applicable very easily with continuous exposures. But it is a very elegant framework, and again, supported by a set of well-defined assumptions, very nice literature. Now, coming to the topic of today's talks, we have also another design, which is the time series design. In this design, usually what we do, we aggregate the data all together through a population to recreate a single series. And so we can measure an average exposures throughout the population. And in fact, it has already been used many times, for example, environmental epidemiologists study air pollution and temperature studies. And of course, you have multiple events, so event counts as a series. And therefore, you can establish, in a way, the association between a given exposure and an health outcome looking at the aggregated data. Now, this study seems very problematic if compared to the others, because of course you're using aggregated data, but it has some advantages. And the advantages are on this very nice temporal structure of the data that allows us to use very sophisticated statistical models to control for trends, and for example, looking at delayed effect and complex temporal relationships. Now, we have all these study designs, and each of them has very nice features and advantages, but none of them, of course, is perfect. So the idea was, what if I can combine and bring together the advantages of each different study design, for example, the individual level setting and the self-matched contrasts of the case crossover and self-control case series, but at the same time keeping the temporal structure and modeling flexibility of the time series. Can I embed all of these in a, let's say, design extension that I call the case time series study? So it's the study design at the individual level, but with a time series structure. The way it works is silly in some ways. You take what is the framework of a self-control case series, but you stratify each of the follow-up of the subjects in separate individual series. And therefore you reconstruct these longitudinal profiles based on a series of a subject-specific series for all the subjects. Now, it looks very silly, as I said at the beginning, but it provides us a very nice data structure through which we can model a very flexible modeling framework. And how does it work? The regression model looks like a time series analysis. So you have, for example, this function f, which can model the effect of the exposure of interest x, also accounting for potential lags. Then you have a set of functions modeling trends and smoothing out, let's say, differential effects due to trends. And in addition, you can add multiple, in a way, time-varying confounders that you can control. So, very simply, a time series structure. What's the difference here is in this bit here, which is this index I, meaning these series are repeated for all the subjects in your group. And especially, I can define these intercept terms that in a way can be conditioned out from the analysis and therefore remove any structural confounding between subjects due to time invariant factors. Similarly, this time to the self-matched individual level studies, just like the case crossover or self-control case series. Now, if the modeling structure is very similar to the time series, the estimation and computational aspects are instead taken from the case-only or self-matched designs. As for the estimators are based on conditional likelihoods, in which within subjects difference are, let's say, absorbed on these subject-specific terms, which are treated as nuisance parameters and therefore conditioned out. So you don't have to measure subject-specific baselines, different, for example, from random effects models, because these are just excluded for the analysis. Another interesting features of this is that you can use these conditional models also for modeling something which is not Poisson, meaning count, because fixed effects models or conditional model exist also for other outcomes, for example, continuous measurements, or, for example, binary outcomes. Therefore, you come up with a very efficient computational scheme because you are just running your analysis on the cases, let's say, and you have this conditional likelihood which can be separated in subject-specific components and therefore are computationally very efficient to run even in very large databases. The other thing is that, as I said before, this is a flexible analytical framework, so coming back to the original example, I can apply it in many different settings. For example, with count events, potentially multiple events, and a binary indicator of exposure, similar to the original example, but the outcome can also be a binary indicator, it can be a continuous outcome, and similarly, the exposure, it can be just a binary exposure, or it can be a continuous exposures measured differently throughout the period at the individual level. Now, a couple of examples to show why this study is very interesting. The first is about analyzing the association between flu and myocardial infarction. So what I did, I took a study previously analyzed using a self-control case series, and it was made through the linkage of electronic records to retrieve information of almost 4,000 patients that experienced an acute myocardial infarction and that at least a flu consultation between 2003 and 2004. Therefore, I have my outcome, which is the acute myocardial infarction event, and exposures, indicators of flu, which can be multiple in the subject, with a lag period covering 1 to 1 days after the flu episode. So, in order to analyze the data, I fit this case time series model with a conditional Poisson generalized linear model, with subject-specific resets. So my resets are the entire follow-ups for all the subjects. And I can use, however, time series method, just like splines for accounting for seasonality and age. And in addition, distributed lag models to analyze this complex lag pattern. This is an example for real data, actually 6 subjects, and we can see that each of them, they experience the outcome, the myocardial infarction at some point, and each of them has at least one flu episode. This subject has just one, and this is my 3 months and 91 days of lag. But some subjects, they can have multiple flu episodes, and these flu episode periods can overlap a bit, which creates a lot of problems in the application of the self-control case series, while is naturally accommodated in that time series setting in which these effects can be accumulated through distributed lag models. So the application of the case time series model returns these results, and what is shown here, it's a so-called lag response curve, basically showing how the risk after a flu episode develops in time. And this is application of 2 different models, in particular a spline model and a strata, step function, let's say, model for analyzing these distributed lag effects in the future in this time series component, showing that after a flu episode, you have a very high risk, up to 5 times the subject not experiencing a flu episode of acute myocardial infarction, but this risk keeps being higher than the baseline, but decreasing, and is still present almost 1 month after the flu episode until it disappears and your risk comes back to normal. So all of this is achieved through this application of the case time series, in which you were able to model also and to control for complex, let's say, temporal trends and other differences. Now, the second example is probably even more interesting, and this is a smartphone study that I collaborated on in a study in Tasmania. Basically, the research question is the association between exposure to multiple environmental stressors are linked with a higher risk of allergic symptoms. So these people, they collected the data through a smartphone using this iRater app, downloaded from 1,600 people in Tasmania during the period from October 2015 to November 2018. So what happened is that people daily reported or not having allergic symptoms, and through the GPS of the phone, the researchers could follow people and assign exposures based on a fine grid reconstructed by spatial temporal maps of pollen, PM2.5, meaning particulate matter, fine particulate matter, which is a pollutant, and temperature. So you can analyze all these data together, again, with a case time series. This time, I applied conditional binomial generalized linear model because the exposure is just a 0-1, having an allergic symptom in that day or not, but using as reset not just the full period, follow-up period of the subject, but stratifying it in months also to account for within subject variations in risks. In addition to that, I use a spline for model common seasonalities, and again, distributed lag models and distributed lag nonlinear models to model the lagged effect of pollen, PM2.5, and temperature. So this again is a subject-specific profile, actually just one, in which this subject reported symptoms in these days and no symptoms in other days. And for at the subject level, at the individual level, it was possible to match a series of pollen, PM2.5, and temperature changing in time. So the application of the case time series reports these results, in which are accounted for the lagged effect up to 3 days for all the 3 environmental stressors. This shows the so-called cumulative exposure response, meaning the net effect, accounting for the lag, showing that there is an increase, a steep increase in the risk of having allergic symptoms for pollen, but these tends to flatten then at very high pollen exposure, therefore a non-linear exposure response. For PM2.5, I use it actually based on the literature, a linear exposure responses, but still there is a significant increase in risk for the effect. And for temperature, I use a nonlinear spline model, and this shows that the risk is quite stable up to 15 degrees of average temperature of the day, and then starts increasing. Even more interesting is the lag pattern that I can explore because of the modeling flexibility of this case time series, showing that there is some kind of lagged effect for pollen in this dimension, meaning lag 0, lag 1, lag 2, and lag 3, and up to lag 3 and lag 1 and 2 in particular, there is still a significant risk. Different is for PM2.5. Most of the risk is just limited to the same day exposure, and for temperature is in between, meaning there is some suggestion of lagged effect, but not very much. Now, in conclusions, very adaptable framework because you can combine flexibility of the time series with the design features of the individual level self-matched methods. Is general because you can apply whatever exposure and outcome you have. Is flexible because you can model flexibly these kind of longitudinal structures. And as I showed, there is a wide applicability because it can be applied in many different settings, just like clinical and environmental studies, as I've just show. Very last thing, and I think it's very important, I'm very keen on that, is this is an example of the R code, meaning once you have set up the data correctly, this is the whole analysis and the whole code you need to write for replicating the first example. Basically, you define a spline transformation of age and seasonality, mean day and age, a day of the year. You apply this cross-basis transformation of a matrix of exposure histories, that is, for each day, for each subject, you reconstruct past exposures up from 1 to 91 days, using, in this case, just an indicator 0,1 for the exposure response, and a spline to model the complex, as we saw, lag responses. You fit the model with existing functions. This GNM is generalized non-linear model, but they are used just to run this conditional generalized linear models in which you have a family, Poisson, and this eliminate is the definition of the reset, in particular, the ID, meaning the subject, and in here you can put one or more terms, for example, cross basis for temperature, a spline for age, a spline for seasonality. Then you obtain a prediction and you can plot the model quite easily. Final thing is about references. This is the article which has just been published this year, called the Case Timeseries, published in Epidemiology, and I was very keen to point to these two resources, my personal website and GitHub, for this very simple reason. Just let me see if I can find it. Oh yeah, it's in here. So this is my website, following that link, in which you can find the full article together with all the appendix, and in particular, it has a link to my GitHub page that I reported there. In this GitHub page, you can find replicable examples, in particular, a document developed in R Markdown that shows how to replicate the full analysis for the two case studies together with code, and therefore you can use it to replicate or apply this case time series with your own data. If you have questions or anything, you can use the contacts here to ask questions. So I will stop here, and I'll be happy to provide any answer if you have any. Thank you very much.
Thank you very much, Antonio, for another very interesting presentation. We do have a question, so I probably will start with a question for you, as everything is fresh. Do the assumptions for the self-controlled case series also apply to the case time series model?
Well, very interesting question. Actually, I was into myself about to put a slide for the assumptions. I didn't because I thought it was too long, while I probably had time to cover it. The assumptions are very similar. And actually, I drew a lot from the literature from Paddy Farrington and the other people developing the self-control case series for algorithm. And there are very strict assumptions that probably are very clear to the people applying the self-control case series, probably less to other people, for example, applying the case crossover. And these are all based on being sure that you keep exchangeable conditions, let's say, throughout your series, either to direct modeling or making some assumptions about the potential associations. In particular, there is these strict assumptions that the exposure is not, well, the having an outcome is not modifying your risk of being exposed, which is a very strong one. Similarly, that having an outcome doesn't have any impact in your follow-up period, which is another strong assumption. But probably the most important one is that apart from the measure, you have a conditional, let's say, exchangeability throughout your series, individual series, meaning your baseline risk is pretty much stable apart from the measurable factors, the effect of measurable factors you can include in your model. And therefore, any imbalance within subjects of risk due to unmeasured time-varying confounders can be catastrophic and lead to important biases. Now, these are all discussed in the self-control case here, so I haven't invented anything, but I have redeveloped a bit in this new context of time series structures.
So there's another question for you, Antonio. So how would you assess the role of potential mediators in the effects patterns observed in order to assess direct causal effects?
I had a very bad fight with some of the reviewers of the paper on this fact, meaning the causality framework in this self-control, in self-match studies are very superficial in a way, meaning they are based on these very strict assumptions, and these strict assumptions pretty much they rule out any kind of complex feedback between exposures, outcomes, and potential confounders. So if you work in this very simple setting, everything works. When you move out from here, that is probably happening in most of the cases, it's very complex. So I must say, all these studies, they work really well in a very neat conditions of transient and very neat effects in which the feedback structure of potential multiple, let's say, characteristics can be assumed non-existent. But of course, this is far from the reality, and it's one probably of the research directions that we need to pursue in order to improve this modeling.
Thank you, Antonio. Laurence, we have a couple of questions for you. So what is the barrier to using a more general approach, not assuming there is an effect at the intervention time?
It's a question of Rebecca. She lived.
Yes.
She lived. And she sent me an email. I don't understand well the question.
Okay, so probably you can review the question after and contact her.
Yes, she sent me an email. She sent me an email.
So there's another question. So have you experienced any difficulties in access to routine collected health data?
No. For the evaluation of the campaign, it was in 2002. It was such easy, but now it's very difficult. You have a committee and you have authorities, and right now, since there is, it's because it was national health insurance database, and the RGPD, you know, the European for data protection. It's
GDPR. Yes.
It's complexified a lot of, and it's very, very difficult. But you have to wait 1 year around to get your data.
And I could add to that, it really depends on the country where you're trying to get data. Because sometimes, like in Scotland, everything is centralized into the government databases, so it's easier to actually request the data. It's a completely different story in England. So it really depends on the health system and consent processes and all of that.
And after, for the surveillance networks, it depends what is produced by National Santé Publique France. It's easy to have because they give you the data, but aggregated data only, not individual data.
Yeah. So thank you very much to our speakers. As someone posted a message saying fascinating event and talks, thank you very much. And I thought that as well. So thank you very much. So I'm going to share.
Thank you very much.
I'm going to share a final slide. So let me just put this. I think you can all see it. So we will have the Royal Statistics Society International Conference next year will be in Aberdeen. So on behalf of all statisticians in Aberdeen, I would like to invite you all to visit us. If you want to spend... Sorry?
Yes, of course.
If you want to spend some time in the northeast of Scotland, I assure you it's beautiful. Let's hope the good weather will join us as well. And I'm sure they're preparing a really amazing series of events. So you are all invited, and I hope to see you all there next year. So it will be between 12 and 15 September, and you are all welcome. So thank you very much again, everybody. Thank you, Mona, for introducing. Thank you, Laurence.
Thank you very much. Bye-bye.
Thank you.
Thank you.
Have a nice evening,
Thank
you all.
You too. Bye. Thank you. Much
Bye.
appreciated. Bye-bye. Thank you.